So I'd like to thank Dr. Lum and Roya, I think, had actually invited me, but she's not here today, but to thank her for the invitation to join you tonight and to speak about one of my favorite topics, which is CT colonography. Now, I first started doing CTC, back in 1996 or so. So it's been a long time and have continued with doing the research. But I really think that it has changed the landscape of colorectal cancer screening, not just in the US, but globally. And there's a lot of satisfaction in saying that we've helped to bring patients who otherwise would have remained unscreened to come in and actually to get the test. So the talk that I'm giving today is entitled CT Colonography Strategies for Success. And I did want to start off, this is some stats from the US, but just to show you that it is a common malignancy in the United States. It remains a common malignancy. It is the second leading cause of malignant deaths in the States. And up to about 50% of patients actually remain unscreened. I found this one article that's pertinent to Ontario, and I did want to bring it to your attention. This is from Linda Rabnick, but the incidence and mortality rates for colorectal cancer in Canada are among the highest in the world. Hopefully you have been aware of that. An extraordinarily low proportion, less than about 21% of screen-eligible men and women in Ontario were screened for colorectal cancer during a 6-year follow-up. So that's quite tragic because, as you'll see, colorectal cancer screening is very different from, I always say, lung cancer screening, prostate and breast cancer screening, in that we know that for the majority of patients there's actually a precursor lesion that if we could just bring patients in to get screened, we can identify that precursor and prevent the cancer from occurring, right? For the other screening tests for lung and breast and prostate, you're actually looking for the cancer, at which point it's almost too late. So let me start off by going through with you sort of the development, and I won't spend a huge amount of time on this, but the evolution of CTC, which first started in the United States. So first introduced back in 1994, and then over a 10-year period up to 2007, there are major performance trials to validate that the technique works. At the same time, there was evolution and research performed looking at animal models, but also looking at optimizing technique. So this is where we moved from single detector to multi-detector CT, where we actually moved from using room air to carbon dioxide insufflation, and then the hardware and software improved for CTC. You might be aware of the Akron National CT Colonography Trial, which was published in the New England Journal of Medicine back in 2008 with very positive results, and we thought that that would actually lead to reimbursement. It did lead to endorsement by the American Cancer Society, which included CT colonography every 5 years in its joint guidelines with the American College of Radiology and the U.S. Multi-Society Task Force, which is consisting of the GI societies in the states. However, subsequent to that, as some of you know, the U.S. Preventive Service Task Force and Medicare in the 2008 and 2009 decided that there was insufficient evidence to support reimbursement for screening. They gave several reasons, and subsequent to that, multiple trials were published addressing the issues that they perceived, which was they wanted more on the effect, cumulative effect of radiation dose for CTC, the cost-effective management of extracolonic findings, and they actually wanted some validation tests performed specifically on Medicare age patients, which are the age 65 and above. So 2009 up to present, there have been innumerable studies that have been published addressing all three of those issues. At the same time, it's interesting in the States, private payers started to reimburse for screening. And it's sort of a backwards approach where typically they wait for Medicare and then they will adopt a similar policy. Here, Medicare is sort of still holding off on it, but private payers have moved ahead. Many of the large ones have moved ahead and actually reimbursed for screening. In 2013, the Food and Drug Administration in the U.S. held a specific joint panel to evaluate the safety and the efficacy of CTC, and it was a very unanimous positive result. The USPSTF evaluation is undergoing now, and we have a draft recommendation statement which is listed preferred and alternate exams, and they have put CTC under the alternate exams. However, that is not a final recommendation statement, so we would expect to hear from them the final recommendation over the next several months. So we're waiting and watching very closely. Also, over the past 5 years or so, we have seen just an explosion of the use of CTC globally. And I'll talk a little bit more about that later, but I can tell you that I personally have gone to multiple of the countries in Asia and Europe, South Africa, South America, and everyone is performing CTC. It's not in huge volumes, but I think that the fact that it's getting out there and radiologists are learning how to perform CTC is a huge step. So what are some of the advantages of performing CT colonography? Well, it's less invasive, obviously, so this should translate into better patient acceptance. It is a safer test than colonoscopy in that the perforation rate is about 20 times lower than for colonoscopy. A very short procedural time, and you can schedule these first thing in the morning in a 15-minute time slot or so. There's no need for sedation, so the patients can actually come in, have the exam, and then go back to normal daily activities. And then it is, no matter how you look at it, is less costly than colonoscopy. It does afford you the ability to evaluate structures outside of the colon. So for example, for a diagnostic CTC where the patient is symptomatic, perhaps with just vague abdominal pain, you might be able to identify the actual cause of the patient's symptom, even with a normal colon. And then in the States, at least, there are not enough gastroenterologists to perform all of the necessary screening colonoscopies in our aging baby boomer population. So what I'd like to do in the next 45 minutes or so is to go over with you what are we looking for? What is the actual target lesion for CT colonography? We'll go through state-of-the-art patient prerequisites, and this includes the bowel cleansing technique, distension, and then performing tagging. And I had a nice visit this afternoon at St. Joseph's, and I have their protocol, so I actually made a quick slide of that, and we can go over that as well. The CT technique has been modified significantly to reduce dose. And I can tell you that it matters whether you have a screening test versus a diagnostic CTC. So for a screening CTC, in the States at least, we've gotten doses down to 3 millisieverts or below, which is quite low because the annual background dose is what? Is 3 millisieverts. So that's what we've got it down to right now. And then we'll review what the requisites are for reader training. Very briefly, because I don't want to get into like a huge number of the validation trials. There have been large numbers performed, but I'll go through with you sort of the major performance trials. And then I want to leave you with some resources so that, I know that you are performing CTC, so that if you have questions, if you need additional resources, you can actually tap into the ACR and the RSNA, and they have them quite available on websites. Okay, so what is the target lesion for CT colonography? I think all of you know that by far greater than 95% of colorectal cancers actually arise in this precursor adenomatous polyp. And this is where size does matter, right? So in a diminutive 1 to 5 millimeter polyp, there's actually a 0% risk that it's actually malignant, all right? 0% risk. That's why the American College of Radiology recommends that you don't need to report anything that is below 6 millimeters. So if you see something that's 1 to 5 millimeters, you can dismiss it and you don't have to report it. The 6 to 9 millimeter category is what we call the small size category, and there's a less than 1% chance that it's malignant. And then you can see that up to 20 millimeters, there's up to a 10% chance of malignancy, and then that continues to rise with increasing size. Now the good news is that for a 10 millimeter and smaller polyp, it takes about 10 years to transition into an invasive carcinoma. So this is an ideal malignancy model where you can go in find that precursor lesion, resect it, and prevent the cancer from ever occurring. You have that wide window of opportunity to do that. Here's some of the science behind what I just said, in that you can see for the 1 to 5 millimeter diminutive polyps, 0% chance that it's malignant, and less than 2% chance that it has advanced histology. For the 6 to 9 millimeter small polyp size category, this is the one that's a bit controversial for the gastroenterologist. You can see it's less than 1% chance that it's malignant, and about an 11% incidence that it harbors advanced histology. And they wanted to take out all of those. Moving along to sort of state-of-the-art technique, we are not there yet with a prepless version of CTC. You know, my site has participated in trials looking at not using a purgative or a laxative, and they certainly do work. It requires extra training, though, I think. It's a very different reading paradigm, and I don't think that it's actually quite yet ready for dissemination. But there are additional studies that are looking at this, and so I think that you'll see more coming out. So colonic cleansing is still necessary, and I'll talk a little bit about our prep in the States, and then we'll go through how very similar it is actually in Canada. So there are two broad categories of preps, the dry prep and the wet prep. And the dry prep basically consists of saline cathartics, and what we use at UCSF is magnesium citrate. The sodium phosphate or the phosphosoda you're all familiar with, we tend not to use that because it is contraindicated in patients with renal insufficiency and patients with congestive heart failure. And so, you know, we don't like to have to check you know, EGFRs and creatinines in all these patients, so we tend to stick with the magnesium citrate. The wet prep category, we have the large volume polyethylene glycol. And in the States, we call it co-light or go lightly. And the joke is that you really don't go very lightly. But it is a large volume cathartic that I think in particular elderly patients have trouble completing the prep. So, you know, it's not preferred also because it leaves behind too much residual fluid that can obscure polyps and also can make the tagging less effective. So we don't like using the 4 liters. I should mention that we have actually done some work and published it and looked at a different kind of polyethylene glycol that has some other additives, but it's a 2-liter product. And that has worked quite well. So in the future, we may be moving to a half-volume polyethylene glycol. What's really interesting, though, is you would think that with half the volume it would be half the cost. But with half the volume, it's almost 1.5 times the cost. And so that has, I think, prevented easy dissemination of using the product. Now, I will mention that there is the ability to combine different purgatives and laxatives. We know that there are certain patients who, often they're older, they are bedridden, so limited mobility, or they have a history of just slow bowel transit. And this is where you're going to need a sort of a heavier bowel cleansing regimen. And this seems to work quite well, which is using sort of the magnesium citrate, but also combining it with the half-volume polyethylene glycol. This is from the National CT Colonography trial where tagging was used. And on the day before the CTC, a barium product is given called Tagatol V in 3 divided aliquots. So at 8, 11, and 2 in 20 milliliters, and then 10 and 10. And the goal of using the barium product is really to tag any residual stool. The patient then ingests the cathartic, and that will evacuate pretty much all of the solid material, or most of it. You can see bisacodyl or Dulcolax tablets are given in the evening. Following that, at 9 p.m., the iodinated contrast is given, and this is, again, is given in 3 separate doses of 20 ml each. And what happens is that after you have tagged the solid stool, you've evacuated most of the solid material, you'll have some residual fluid, and this is where the iodinated contrast comes in, and it tags the residual fluid. So ideally, what you have left is none of the sort of sticky material. What you'll have is just a small amount of residual fluid that is homogeneously tagged. you know, there's never just one way of doing things. So this is from the University of Wisconsin, and they use a double dose of the magnesium citrate and perform tagging. And so on the day before a clear liquid diet, obviously, and they give the Dulcolax or the bisacodyl tablets in the morning. In the early afternoon, or 5 p.m. actually, they give 300 ml of the magnesium citrate as the first dose. And then 3 hours later, they'll give a larger volume of the low-density barium product. And then they follow it with the second dose of the magnesium citrate. Iodinated contrast is given fairly late at 11 p.m. And they say that the true bowel prep period is between 5 p.m. all the way into the morning. And we sort of have tried this at our site, and it's kind of tough because, especially again in older patients, they tend to be up pretty much all night dealing with the prep and the restroom. And I think that, you know, the Akron CTC protocol is a bit more acceptable and doable for the elderly patients. This is the St. Joseph's CT colonography prep protocol. On the day before the CTC, you can see that there are 2 doses of the Picosalax that's given at breakfast and then at dinner. Barium is given in a larger volume, and it's the lower density barium product, so 100 ml for breakfast and then 350 mLs for lunch. And then in the evening, the patient will take 30 mLs of gastrografin, which is half of what we give, actually. And then they will take Dulcolax suppository, and then Dulcolax suppository again on the morning of. And apparently this works quite well. So it's a similar strategy, I think, with giving the gastrografin after you give the barium product and after you give the purgative. Did you notice the purple color? Okay, so yes. That was, all right. Okay, that was Matt. Thank you, Matt. There you go. And this is what you want to see, is this homogeneous tagging of residual fluid. So it's, you don't have, you know, 50% or more of the lumen filled with fluid. You really have very small fluid pools, and what's left is homogeneously tagged. And then some of the software out there performs electronic subtraction for you. And here's a nice demonstration of, with electronic subtraction, as you're scrolling through this, none of you, right, will miss this polyp. Not even neuroradiologists would miss this, right? Okay. This is a sample of our prep sheet. And it's so important to have, I think, clear instructions for the patient. And what we found is that they respond really well to graphics. And so sort of drawing it out for them works very well, and showing them what they should mix also works very well. But this is just a sample, and I was able to get the one for St. Joseph, which seems to work very well also. Now for colonic distension, we moved over to using the electronic carbon dioxide insufflator, I want to say over 10 years ago, and have not turned back. This is really what you want to use, because it provides consistently more optimum distension for CTC. The techs like this much better than using the manual bulb insufflation, where because the CO2 is resorbed across the colonic mucosa, they can't pump that blue bulb fast enough to obtain ideal distension throughout the entire colon. So why use carbon dioxide is because it has high lipid solubility, a high partial pressure gradient. So there is resorption across the wall. After the patient has finished the CTC, they're actually much more comfortable, we found, compared to using room air, which is predominantly nitrogen. This is what I advise. I think most sites use this. Our typical is to scan in supine and prone, unless we have a very high BMI, large patient, in which case we recommend scanning the patient in right and left lateral decubitus views. But in the prone position, you'll notice that we actually prop the chest up with pillows and then put a wedge underneath the thighs to lift the trunk off of the CT scanner table, so that it allows easier retrograde progression of the CO2 into the right colon. And obviously the arms are above the head. This is what you want to see with a focus in this area. Why the rectosigmoid is because most colorectal polyps and cancers occur in the rectosigmoid, all right, about 60%. So you need to make sure that you have adequate distension so that you can clear these segments. And it's also the segments that have the most trouble, particularly the sigmoid, because of muscular hypertrophy and diverticulosis, right? But you want to make sure that you're able to get all the way over to the cecum. You want to use your scout also to get a lay of the land. This just happened to be a very complex colon where here's sigmoid, comes all the way up into the right upper quadrant, all right? Then it comes back down, across over, up the descending, here's the transverse, here's the right colon, here's the cecal tip. So your cecum and ascending colon is actually medial to your sigmoid, all right? Imagine how difficult this colonoscopy would be, all right? Also, here's a patient with a ventral hernia containing a fair amount of the colon, and they were not able to complete the colonoscopy. So we get the call, and we're easily able to insufflate and to clear the colon that's within the hernia sac. Here's a patient who has malrotation. The gastroenterologist was able to get just up to here, could not negotiate this acute turn. Look how nicely we're able to clear the right colon. It was actually not in the right anymore, but the ascending colon and the cecum. Same patient, okay, and you can see that the cecum is located right here. Here's the TI coming in, and this patient actually had a bonus diagnosis of what? Polysplenia, right? Which he didn't know before he came for a CTC. Distension is critical in being able to identify lesions, and this sort of highlights that. The yellow arrows are pointing to areas of suboptimal distension or collapse, and you can see that it's very hard on the 3D view to pick out lesions. Whereas if you have better distension, you can see how crisp the colonic folds are, and much easier to pick out lesions. This is just to show you that with the very large patients, it's very doable to scan the patient and to obtain excellent distension in the right and left lateral decubitus views. And this is the overview that we were able to get in this very large patient. In terms of CT technique, you'll notice that as we increase from 4 to 64 slice, the collimation continues to decrease, and we use a 0.625. Effective MA continues to decrease, and so actually to continue to decrease dose, we will scan in 50 effective MAS in the supine at 50, and then in the prone we actually decrease that to 25. And that has helped us to bring our effective dose down to about 3 millisieverts or so. And then scan time continues to decrease to only 5 to 7 seconds using this protocol. Let's talk a little bit about radiation dose, and I mentioned that the annual background dose is at 3 millisieverts unless you live in a high altitude area like Denver in Colorado, at which time you can see that it's actually 12 millisieverts, so 4 times what you would get in other places. The effective dose range, there are multiple papers that have been published looking at effective dose. And in some of the older studies, you can see it's the 5 to 8 millisievert range. However, and you use this here as iterative reconstruction, we've gotten that down to 3 millisieverts and below. And if you use sort of the model-based iterative reconstruction, you can bring that to below 1 millisievert. The Health Physics Society put out this statement, which is below 50 to 100 millisieverts, the risks of health effects are either too small to be observed or are non-existent. So when we're at 3 millisieverts, you can see how trivial that really seems, right? This was a study that was published in AJR that really looked at the number of colorectal cancers prevented from CTC versus the number of radiation-induced cancers from CTC screening every 5 years. And there was a very high benefit to risk ratio. That means that it's a good thing, of 24 up to 35 to 1. And you can see that the number of colorectal cancers prevented per 100,000 patients is much, much larger than the number of radiation-induced cancers per 100,000 patients. Now, how else do we reduce dose? We will not perform CTC if it's a patient who is more than likely to undergo colonoscopy anyways. So if a patient has inflammatory bowel disease or polyposis syndromes, you know what, they really do need to go to colonoscopy. Don't bother with doing the CTC. because they need their biopsies. As I mentioned before, in the supine, yes, we use the effective MAS of 50, but in the prone position, we've actually cut that in half, and that's been very helpful. Now, you'll find that, in evaluating extracolonic findings, it's going to be tough on the prone views, right? But we'll do that on the supine views. I think that having well-trained technologists is very important, and that will help you to limit the number of rescans. And then if you do have to do a rescan, really only do it in a focused volume. So don't rescan the entire abdomen and pelvis, just really look for that portion of a segment that is not cleared, and perform a decubitus view. Typically it's sigmoid, but only in that portion of a segment. And then obviously use iterative reconstruction, and most sites are using that at this point. So just to show you that there really isn't a huge impact on image quality for CTC, this is with filtered back projection only, so 0% iterative reconstruction at a 50 MAS. This is with 40% iterative reconstruction at half the MAS, 25 MAS. And you can see that the dose decreases from 7 all the way down to 3 millisieverts, almost a 60% reduction in dose. And when you look at image quality, this polyp, which is in the large size category, you can see equally well in the reduced dose image. Now, what's interesting, this is from a paper from published in AJR, but it shows you that as you decrease dose, if you add in iterative reconstruction, it actually helps to get rid of some of these artifacts that you would see with very low dose on 3D images if you did not use iterative reconstruction. So if you have iterative reconstruction, use it, because it will help you probably most often on the 3D views, and I find that it's probably less useful on the 2D views. Now this is pulled straight from our dose report off of a CTC study, and you can see that the DLP is about 200, right? You multiply it by the conversion factor of 1.7% for abdomen and pelvis, and the estimated dose is going to come out to about 3 millisieverts, all right? So this is exactly what we're getting today. Let me shift a little bit just to, and I don't think I need to convince any of you of this, is that there are multiple validation trials that have been performed, quite large ones, from multiple authors from different countries that really have shown very similar results, excellent results, I should say. And what I have here is the Akron National CT Colonography trial, the Munich trial, and then the Impact trial out of Italy. And you can see that for the 9 millimeter and 10 millimeter and larger lesions, there's 91% per patient sensitivity to identify the lesions. Now, the sensitivity does decrease with decreasing polyp size, but you can say the same thing for colonoscopy, right? So as polyp size decreases, the sensitivity for the polyps on colonoscopy also decreases. And all of these studies were performed using colonoscopy as the reference standard. And I think that the clinically significant lesions are the ones that are, the 9, 10 millimeter lesions. So we certainly are doing extremely well for those lesions. The impact globally, I think, has been felt. Even in Canada back in 2008, I think all of you are familiar with Giles Stevenson. Back then he said it's beginning to seem rather irresponsible to continue to offer routine double contrast barium enema. More than 90 Canadian radiology departments have purchased the necessary CO2 insufflators. I'm sure it's much more than that now. This is out of Israel. You can see this was during a 7-year period. Over 15,000 CTC exams were performed. They were using, already back then, they were using state-of-the-art technique with low dose. And they had 18 radiologists in the country who were already performing CTC. Now, I don't know how many in total they have, but it seems like they probably have read quite a few CTCs. If you only have 18, it's over 15,000 studies. Out of Sweden, CTC is currently performed in 42% of radiology departments. Of those not performing CTC, 38% intend to start shortly. This is out of Korea, and the Korean guidelines state that CTC is a valid option for colorectal cancer screening. And then finally, Hong Kong, it's very interesting. You would think that bronchogenic carcinoma would be the #1 cancer in Hong Kong because there's a lot of smoking. But in actuality, colorectal cancer is the most common #1 cancer in Hong Kong, and they held their first training for CTC back in 2014, and they have implemented CTC. So in talking about reader training, I think that this is where the American College of Radiology have sort of really led the way in trying to make sure that a reasonable number of cases are interpreted prior to being able to perform and interpret the CTCs in clinical practice. And what's required is that the reader have specific training in patient preparation, insufflation, and then the CTC low-dose protocol. And then they require an interactive review of at least 50 colonoscopy-proven CTC cases. And the recommendation is that you attend one of these interactive hands-on workshops. Maintenance of competence is also suggested, and this is very doable, 50 cases every 2 years, right? So they've made sort of I think, a suggestion that many sites can follow. There are different interpretation methods. You've heard of the primary 2D method and then using 3D for problem solving. Here's a patient where we're using primary 2D, and you use a magnified view of your axial image in supine and in prone in this particular patient. And you can see that what I've highlighted there is actually a beautiful pedunculated polyp on the 2D, and then you can see in the prone in the bottom right-hand corner is the 3D view of that same polyp. I would say that it is pretty hard to sort of understand what's going on the supine view. It looks like it could be a sessile type lesion. It's really on the prone view where you're nicely able to pick out the pedunculated morphology of this lesion. Now, this particular software allows easy ability to obtain measurement of the largest diameter of the lesion. It automatically tries to estimate that for you. And not only that, it also puts down a volume and then the distance from the anorectal junction. So all of that can be obtained with just the click of a button, all right? These are your 3D options for problem solving. You have your traditional endoluminal view and then the subvolume cube view. I tend to be a primary 2D reader, and then I will use the cube view for problem solving. There are readers I know, and again, because the sigmoid is a particular area that you need to clear, who will, if you're a primary 2D reader, is that you will do limited 3D endoluminal fly-through just through the sigmoid. And that's one way that you can deal with doing both of them, but in an area where you're particularly concerned. Here is a pedunculated polyp. You can see quite large. You can also see it on the 2D views. Here it is sitting on the sagittal reformat, on the coronal, and then here sitting in the axial view. Here is an endoluminal view. The green line is the center line that's generated by the computer algorithm that we're flying along. Here's a pedunculated polyp where we can stop, turn back on this. And when we're reporting pedunculated polyps, we're really interested in just the size of the head and not as much on the stalk. That's what the gastroenterologists want to hear. And this particular software has a translucency view that is density-based. So the color reflects the density of the particular lesion. And you can see a red core in this particular algorithm shows you that it's soft tissue and more likely to be a polyp. Okay? The holes in the wall are what? Are the diverticula. Okay? Now, what's the classic appearance of stool, which is going to be the probably your largest pitfall, particularly if it's untagged? You're really lucky if you have a heterogeneous appearance, such as in this particular patient, but also if it has linear, angulated, or a branched morphology. And this looked quite branched, but this is classic stool. And on the 2D, you can see the heterogeneous appearance. Now, in contrast, a polyp's soft tissue density is rounded or ovoid in morphology, right? Again, here, just to emphasize, for the diminutive 5 millimeter and smaller lesions, you don't have to actually report them, but you do need to report the small and large polyps. A very classic appearance. Here's a typical pedunculated polyp. You can see that you can get coating of the polyp by contrast material. And there's some studies that show that if you have contrast coating, there's increased likelihood that there is villus morphology. So that's something I think to watch out for. Now, the 3D view can be very, very helpful. And here's a patient who's very difficult to sort of figure out what's going on, I think, on the 2D views. But the 3D view basically shows you exactly what we have here. So here's pedunculated polyp number 1. Here's the stalk, and here's the head, right? And this is reflected in the 2D view here. When you turn your head and you look this way, here's the long stalk of pedunculated polyp number 2, with the head of polyp 2 hiding right behind this fold. And here it is extending from this very same fold. So we have 2 pedunculated polyps headed in different directions, originating from the very same fold. And here it is on the endoluminal view. Now, I mentioned that when you have angulated morphology, you're thinking about stool, you have to do your due diligence and check your 2D views for soft tissue density, because you know what? You can have irregularly shaped polyps that have this very sort of angulated appearance. And here's just 2 examples of that. Here's a polyp which has more of a linear sort of bulbous type appearance. Here's another one with a discoid morphology. And again, this was a very interesting one where, is this a polyp? It really looks very strange, doesn't it? But when you look at it on the 3D view, it certainly looks like it's a pedunculated polyp that's actually compressed by the inflated rectal balloon, all right? So that's why it has this angulated morphology on the 2D view. It's actually a true rectal polyp, but it's just being compressed by the inflated rectal balloon. And just to let you know that there are reports showing that when you inflate the rectal balloon, you can actually miss polyps. And so in the top row, you can see, would you call a polyp here? No, right? When you deflate the balloon, lo and behold, look at this polyp has sort of popped out, right? So especially with the smaller lesions, you inflate the balloon and it really can hide and obscure some of the smaller polyps. We're going to talk about pitfalls now, and I'm going to go through this quite quickly, but I think that the fixed, adherent, homogeneous stool, if you're not performing tagging, is a big problem. Or if you're performing tagging, you happen to have stool that remains untagged. This certainly looks like a polyp, right? We reported it as a polyp. There was no polyp there. It's just adherent stool. Bulbous folds on the 2D certainly looks like they could be, one of these could be pedunculated polyp. It's just not very well distended. This is often in the sigmoid, and when you check the 3D view, all that you see are these thickened folds. You can have the rotated segment. So the right colon and the sigmoid colon are on long mesenteries. They tend to move around quite a bit when you turn the patient from supine to prone. So the colon can also rotate and bring the polyp along with it. So here's a lesion that's sitting anteriorly, and here that you can see that it's actually shifted. The whole segment has actually shifted and brought this lesion along with it. So it's not a different lesion, it's the same lesion, and it's not mobile stool, and this was a true lesion. Of note, in patients with hip prostheses, they can have beam hardening and can sort of give you a misdiagnosis of thinking that this might even be a lipoma, because when you look at it on the soft tissue windows, it looks like it's very low density, but don't be fooled by that, all right? And you cannot put a cursor and measure the Hounsfield units because it'll be off. This was a proven soft tissue polyp on colonoscopy. What about this case where you see multiple protrusions into the rectal vault? Well, you look at it on the 3D view, and what is this, right? Just internal hemorrhoids, all right? You have a complex rectal venous plexus with contributions from the superior, middle, and the inferior hemorrhoidal veins, as well as the middle sacral vein. And this is what it looks like on colonoscopy. Pitfalls on 3D, it's going to be stool again. And this is where when you have this much stool, it's really hard to exclude anything. You go to your 2D views, it might be a little bit easier because you can see the heterogeneous appearance of the stool on 2D. Now here's a patient, and this looks polypoid, but when you look at it on the 2D, it's just an impacted diverticulum that protrudes into the lumen. Diverticula the classic teaching is that it has a complete black rim. I always say that when you look at a polyp en face, you also see a complete black rim. This easily could be the appendiceal orifice as well. And the key here is that the black rim for diverticulum or for the appendiceal orifice is actually a much darker black rim compared to what you would see around a polyp. All right, so that's one of the, I think, key points. Now, here is a very nice looking polypoid mass lesion, right? When you look at it though on the 2D view, what do you note? The density is exactly the same as the pericolonic fat. So this is just a lipoma, nothing to worry about. And look at this, it's quite scary looking, isn't it? But you look here, then on the soft tissue window, again, just a fatty lesion, all right? Now, the ileocecal valve can also be quite fatty. This is the typical appearance when it does contain quite a bit of fat. It looks like lips, and there's a central depression sitting right here. And you can see the fatty nature of the valve. Now, remember that the valve is covered by colonic mucosa, so you can actually develop adenomatous polyps as well as adenocarcinoma on the valve. And here's a patient who has an adenomatous polyp that developed on the valve. Here's a grossly distorted ileocecal valve. There is a little bit of fat sitting right here, but this turned out to be an ileocecal valve carcinoma. And they start to look alike after a while, but here's just huge soft tissue mass that envelops that ileocecal valve, very hard to pick out any normal ileocecal valve, and again, a carcinoma. And here's yet another one with the colonoscopy correlate. You can get mass-like appearance in the colon, and it can be due to extrinsic impression. So when you look at this on the 2D views, what you note is this is actually the right kidney that's impressing on the colon. What about this case where you see this sort of mass-like appearance in the colon? When you look at it on the 2D, it's actually a small bowel loop that's crossing in that area and impressing on the colon. There are pitfalls that you can see on both 2D and 3D. And again, stool is going to be a big one. There's an entity called hypertrophied anal papilla that basically is a benign entity representing these inflamed glands with chronic irritation. They can enlarge and they can actually herniate into the lower rectal vault. I think anal condyloma in HIV positive patients can occasionally cause a similar appearance. You have the rotated colonic segment, which we talked about before, and then the flat lesions, including the carpet lesions, which are more commonly right-sided, but also relatively flat. And then you have the inverted appendiceal stump. So let's take a look at some of these entities. And here's a patient who has a couple of small polypoid lesions right at the anorectal junction. Here it is on the 3D view. You can see the rectal tube sort of sitting right between them. And then on the colonoscopy. So what do you think this might be? At the lower rectal vault, has this classic sort of pearlish white appearance, completely benign. This is that entity, hypertrophied anal papilla, okay? Flat lesions are tough, and I would say, can you pick it out on the 2D view? I think it's actually easier in this patient on the 3D views, but here it is sitting right there. Using your soft tissue windows will help you. I think that what we do is that we'll run through on 2D using the colonic windows, but then at the very end you really do need to run through the entire colon again on 2D using soft tissue windows. And one of the purposes is really to see if there may be a flat lesion hiding there. Can you pick it out here? Tough, right? On the soft tissue window again. And also, I think that one of the things that we've noticed and that I think some of the experts who have done a lot of CTC have noticed is that you want to use your contrast, the tagging to your advantage. And we've found that you can pick up flat lesions and other lesions better because you see contrast actually on its surface. And that highlights for your eye to travel straight to that lesion, and don't discount it if you see it, okay? So you see contrast coating something, take a closer look at it. because it may be just contrast on top of a specific lesion. So here's a case. I'm going to go through this and see if you can pick out the flat lesion. Can you see it? Yeah, right? And I think that this, you do see it anteriorly. I'm going to show you right here, right? And you do see some contrast sort of sitting on the edges of this lesion. And here it is even coating a little bit more of it. But it does sort of draw your eye to that area, doesn't it? And so use the contrast coating, and here it is confirmed on the colonoscopy. Again, so tagging can help you to find these flat lesions, and here are just some examples. So on supine, sitting right here, there may be a lot of contrast and maybe a little bit disconcerting because you might think, well, is this all just contrast? But I think that if you change the window, you can see that there is soft tissue sort of hiding right underneath it. And then tagging can help you find other types of lesions, not just flat lesions. And so this is a tough one. And I really, I think that a lot of people have struggled with this case, but it's sitting right on a fold on both sides. And you can see it here on colonoscopy as well. But when you go back and you look for this, what highlights it is what? Is the contrast coating, right? And that really sort of draws your eye to it, and you won't miss it. We talked a bit about the appendiceal stump being a pitfall. If you have the correct history, obviously, and you see a polypoid lesion sitting at the cecal tip, then this is in your differential. And this is the same patient. Here's the TI coming in here, and here's the cecal tip, and this was an inverted appendiceal stump. Certainly looks like a beautiful polyp, though, on the 3D, doesn't it? And what about this case? This was really unusual. So this patient did not have history of an appendectomy, but had this sort of long protrusion into the cecum, right in the area of where the appendix should sit. And what we found is, and confirmed with our gastroenterologist, is that if you have an appendix that's relatively shorter, the entire thing can actually invert and then protrude into the cecum. So this was the entire appendix inverted, not just a stump, okay, and caused this appearance. Okay, what's the future of CTC? I think that we have to look at this as a screening test. We want patients to come back. Right now, the interval is at every 5 years, and so we have to make it as appealing as possible. And what do they complain about the most? Is the prep, right? So anything we can do to make it more appealing, less rigorous for them would be helpful. So this was a study that we did using the half-volume polyethylene glycol. And we found that the half-volume PEG was actually equal to the mag citrate for the cleansing, right? So it was as adequately cleansed. And patient tolerance was also equivalent, but there was actually better tagging with the 2-liter PEG compared to the mag citrate, which was quite interesting. So we're looking at this more, and again, one of the hurdles we have to overcome is the cost. And so this was a specific prep that was out on the market and is out on the market that was just very expensive. And we're going to look at just taking the regular polyethylene glycol 4-liter jug and asking patients to ingest half of it, right? Because it's less costly than using the 2-liter. I know, it doesn't make sense. Except to the vendor, it makes sense, right?
Is it just packaging?
It's, yeah, it's the vendor has decided that they're going to make it costly. And I think that has prevented us from disseminating it as a prep for CTC. So there are non-cathartic trials that have been published. There are 3 of them here. All of them basically show that you don't have to have a prep. We participated actually in the first trial by Zalis et al., which was published in the Annals of Internal Medicine in 2012. And I can tell you that the reading paradigm is extremely different. And you will find that these are actually, a lot of us would consider much tougher to interpret. So I think they're challenging, but with appropriate training, that you can achieve high sensitivity, and this certainly was achieved in these trials. So just to let you know, I'm not going to go through these in detail, we don't have much time, but I do want to let you know that there's continuing evidence building for non-cathartic versions of CTC. And I think the gastroenterologists even say that if you were able to perfect that, that really would help to disseminate CTC quicker and more broadly. Novel displays, and the hope is that we would be able to be extremely time efficient and to really look at a larger portion of the colon at one time. At the same time, we want it to be intuitive, and we want it to have high accuracy. Computer-aided detection has to be incorporated with it. This is the fillet or the dissection view from a vendor, but you can see that it has that wobble as you move towards the center, so you can see in front of and back of the folds. What's highlighted in blue is targeted by the computer-aided detection program. So, the fillet and dissection view is used in Asia as a primary reading tool. I think in the US and in Canada, we use it. If we use it, it's usually as a confirmatory type view, and has not been integrated in as a first reader for us. And just to show you, there is a fair amount of distortion. This patient has a larger mass that turned out to be a carcinoma, and then a large polyp as well. This is what it looks like on the dissection view. A little bit tough, I think, to evaluate, but here it is. Here's that large mass, right? And the polyp is sitting right here. It looks like it's duplicated because they actually do duplicate a portion of this so that you see the entire 360 degrees of the lumen. And this is correlated with the histology. There's a band view where basically you are sitting in the lumen and the folds rotate around you, right? You're not, yeah. And so can be combined with computer-aided detection. And so easily you can just sort of sit there, your eye is looking for the CAD marks. So quite nice as well. And then there are these combination 2D, 3D views where, in particular, when you look at the axial combined with the endoluminal, here's a soft tissue polyp. So as you're flying through, you can automatically look at the density of the lesion. Wouldn't that be great, right? And so just to show you, we're going to come across that same lesion. Here it is coming up, and automatically, oh, that soft tissue density. That's a true polyp, right? See how quick that was? Okay. And then just to show you that, the DoubleCon BE has fallen, I think, in appropriateness criteria rating from the American College of Radiology. It used to be at an 8, it's moved down to a 6. CTC, which was lower, has now moved to a 9, and you can see 9 is the highest grade that you can get. So it's considered the most appropriate imaging test for colorectal cancer screening. The American College of Radiology has also developed NEARDEAR, which is a national radiology data registry, and CTC is a part of that. The purpose of the registry is really to make sure that sites are performing CTC with quality. We want to make sure that we are maintaining low dose, and eventually to support credentialing and reimbursement. So we're ready for that. There are 6 quality metrics that are included, and 3 of them are process measures and 3 of them are outcomes measures. And I think that it's actually quite easy to achieve all of these. So the process measures are adequacy of bowel cleansing and distension, and then also the rate of technical adequacy for both screening and diagnostic studies. The outcomes measures are how many colonic perforations you have, and then the true positive rate really for the large polyps only, so for the 10 millimeter and larger lesions. And then your percentage of clinically significant extracolonic findings. And we've been part of the registry since it started, and I can tell you it works quite well. So the ACR certainly encourages sites to register. Also, this is a website you should know about and refer to. There's basically A to Z about CT colonography. It's got a lot of the literature right there for you so that you don't have to hunt around for it. There's a lot of educational material for referring physicians, but also for patients. And so there's a very patient-friendly brochure you can see that you can click on, download, and use it at your site. In the States, we also include a lot of private payer information for sites as well. So this is just our outreach in March, was Colorectal Cancer Awareness Month, and you can see that a new video was put out through the ACR, and the outreach is to underserved populations, and we actually have translated into Spanish this very easily downloadable brochure. RSNA has this site that some of you may be familiar with, which is the radiologyinfo.org. And so, again, there's a lot of easy material. You don't have to reinvent the wheel. You can go and just pull down and just look for the sheet and download this, and you can give this to your patients. But basically goes through, you know, what is a CT colonography? And it goes through, you know, what the preparation is like, what does the equipment look like. It's very easy and very useful. Okay, so one of my summary points is that I think I've shown you that CTC is validated as an effective and a safe screening test. The benefits of screening clearly outweigh the radiation risks, and the current techniques that I've shown you decrease the dose by up to 60%, and we've gotten it down to 3 millisieverts or below, and that's equivalent to annual background dose if you don't live in Denver. Okay. Increasing support for CTC as a screening tool globally. In the States, the American Cancer Society, the FDA, and some of the large private payers already support screening CTC. And then I've left you with some resources where you can easily go and find out more information, or if you have questions, feel free to email me, actually, if the website isn't helpful to you. So I thank you very much for your attention. Thanks so much.